thanking you guys so much for, one, letting us come up here and present on this really important topic, and two, agreeing to be one of our pilot sites. We're looking, as Colorado ACEP, to do some really exciting things with some of our partners, Colorado Hospital Association, Colorado Consortium, et cetera, across the board, to really make a difference in how we care for opioid-addicted patients, and then also how we create less people addicted to opioids in Colorado from here going forward. And I think that the ED has a really important role in that. So just so I get to know, how many of you during your last 1 or 2 shifts actually dealt with an opioid-related issue? Yeah, right? Pretty much everyone raises their hands, because we're seeing a ton of people who are either, one, coming in seeking opioids, or two, addicted to opioids who have overdosed, right? When was the last time that any one of you saw someone who overdosed on an opioid? Last week, right? This is something that's become really bread and butter emergency medicine, right? And it's also really tragic emergency medicine. So the pictures behind me, I think a lot of people will recognize them, right? Do you guys all recognize these pictures?
I remember that one was on the news.
Yeah, this one was on the news. This one was made big waves because it was on Facebook, right? This is what people think is the photograph that defines this opioid epidemic, and it's this couple in Colorado who have custody of this 4-year-old who have both overdosed in their car, right, with a 4-year-old in the back. And the police took pictures of this and posted them with some controversy, just to show how bad that this problem was in their local community. Does anyone recognize, this is a more obscure story, perhaps more sad story, that's on the opposite end of the screen. This is a story from Pennsylvania at the end of last year, where a mother and her husband, both of whom decided to use heroin, used heroin and died in their house, and their 5-month-old slowly starved over the next 4 days and ended up dying as well. And it's tragedies like this that make this epidemic really, I think, fill people with a lot of disgust, but also really should motivate us to want to change how we're practicing. Now, when a lot of people view these, these two really extreme cases, what are most people's thoughts? These motherfuckers, right? How could they overdose with a child in the house or in the back of their car? Incredulous, right? Who would do that to a child? Who would put that child at that type of risk? These addicts, right? I mean, you can be honest. You have a negative perspective about these, right? These patients who struggle with addiction. And that's really backed up by society. But I think you get a little more humble when you realize that 4 out of every 5 addicts starts with a doctor. It starts with a prescription that a physician writes. 80% of our heroin addicts gets their start with medicine. Traditional, good old-fashioned, control the pain medicine, including medicine that begins in the ER. And the numbers are disgusting, right? They should fill all of us with rage. Because of medicine and because of how opio-liberal we've become, the number of overdoses that we've seen has skyrocketed. Right? 33,000 people, Americans, dead, right? Just in 2015, the last year we have data. That's 10 9/11s, 10 plus 9/11s, 10 planes running into buildings, right? Just in 1 year. That's more than car accidents, that's more than homicides. This is the biggest public health emergency that we've faced in generations. And we have a huge role to play in creating it, and also in bringing our society back from that brink, right? This doesn't just affect, these aren't abstract numbers, this is happening in our communities. This is from the Harm Reduction Action Center down in Denver that was posted 2 weeks ago. 5 people dead who were their patients who were there trying to take care of in 1 week because of a bad batch of heroin. Maybe laced with fentanyl, maybe just stronger than it was usually. And this is a story that repeats itself over and over and over again in communities here in Colorado and across our nation. In Colorado, the most recent data says 472 people died in 2015 of an overdose. In the rest of the country, that's usually more than car accidents. But Colorado, we have worse roads, we have more transplants. People don't know how to drive in snow, right? And the other thing that I think is a success story with this is Colorado has also been a leader in naloxone. So naloxone and pushing that out into the community, and the number of people saved are the reason why that number isn't higher than car accidents, right? Because there's hundreds of cases, documented cases, Denver, Boulder, across our state, where people who would have died of an overdose were saved because we liberally prescribe naloxone and people can get it over the counter. So in some ways, that last graph and how it's flattened is a success story from our state. It's not just about people who overdose. You guys know this because you take care of it every single day. People who come in with opioid-related complications, be it constipation, right, or altered mental status. People who come in because they're withdrawing and they want help. People who come in because they overdose. People who come in because they're trying to get an opioid from you, right? This is bread and butter emergency medicine. We see a ton of this, and we need to treat it better. This is a pretty stark graph, but you guys seen this image? No? Okay. Well, this just tells the story in basically two pictures. So this is overdose rate back in 2002. This is 2014. Right? Every place in the country, in our state, has gone up in the number of overdoses that we see. It's gone up in the amount of opioid-related complications that we're seeing. And this is the same story across the country. Now, anytime that you get a public health crisis that gets this large, you get a lot of different people who want to come out with guidelines and tell you what to do, right? That's part of the reactive nature of medicine and kind of the reactive nature of public health in a lot of ways. And I can summarize most of those guidelines in one word. That word is no, right? Don't give, don't prescribe, no, 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 no. How many of you think that we're really going to know our way out of this? Okay? No. No to no, right? So what we did with Colorado ACEP is we had a string of bad overdoses. We got together as a board, discussed these, and we said we've got to do something, and we've got to do something that's not being done across the country. As we've got to take a better look at this and a more complete look at this. And we assembled over the last year a task force of 25 people, doctors, people from the addiction community, people who were addicted to opioids, people from the harm reduction community. And we said, how can we do this better? How can we do this in a holistic way to really address this problem and address it with some of the best science, et cetera, that we can, and really improve the health of our patients here in Colorado who are addicted to opioids. So what we came up with was this. We came up with not just a thing that says no, and no is damn important, by the way, right? We've got to limit the amount of opiates that we're prescribing. We've got to limit the amount of people who we expose to this dangerous drug. But if we're going to limit that, we sure as heck better have other things that we can control pain with. So we have a whole section on alternatives to opioids, which is a lot of what the pilot that you guys have agreed to sign on to focuses around. Then for the people who are addicted, harm reduction. Harm reduction is perhaps one of the things that we should have brought into the emergency department around heroin, IV drug use, opioid addiction a long time ago. But I'll tell you what, we have not done so in a very good manner, and that's something that we really have to change. And the last thing, which is perhaps the most aspirational of all, is the fact that we need to treat our addicts better, and we need to get them into places like medically assisted treatment programs or other programs that could really help address their addiction in a more complete way than what we're doing now. Okay. So, limiting opioids from the ED. Looks like we're doing a bad job, right? And there's two things. This was just from the news the other day from NPR. You may have heard about it. That they do a survey every year of a few thousand people, and they say, hey, how many of you have been prescribed an opioid? And the number is now 56% of the people surveyed. That's up from 2010, which was 50%. But when you think about it, 56% of people through their adult lives gets prescribed an opioid. How many of you in this room have been prescribed Norco or Percocet or something for any type of issue? I got my teeth extracted. I got a prescription. The majority of us is exposed to a narcotic, an opioid, throughout the course of our lives because that's what we do to treat pain, right? So this kind of comes in question form, and it's supposed to be a little bit interactive, but I'm going to ask you all, what's the most dangerous class of drug that we prescribe? By far. Okay. Anticoagulants. Yeah, good call. They are a dangerous class of drugs, but 33,000 people probably don't die from anticoagulants, right, every year. But very dangerous. The most dangerous is opioids, right? And when you think about it, they're really a horrible class of drug. They give you a ton of euphoria for people who take them, right? The other thing is that they're rapidly addictive. Your body gets used to them. They're terrible in withdrawal. So people who try to get off them, there's negative reinforcement that drives them to use again, right? They have a very low therapeutic window. You take too many, game over, right? They have a high side effect profile when it looks at just normal usage and the amount of side effects people get, and they've got terrible interactions with other drugs. That to me sounds like a really crappy drug if I talk about all that to prescribe to my patients, right? If you know and you think about how bad they are, I'll tell you what, your desire to prescribe a lot of them kind of goes away, or at least it relinquishes a little bit. How many of us perform a risk assessment before we prescribe this? I don't see a hand up in this room, right? Risk assessment's really easy. I ask this, and I've added this to my practice, 3 questions, right? 1, have you ever been addicted to any substance? Yes, alcohol. Well, you're high risk, right? 2, do you have a family history of addiction? Yes, my grandfather or my dad's addicted to booze or something else. Hey, they're higher risk. And then 3, one that's, do you have a history of mental health? Any depression, anything else like that? And if they say yes, they're higher risk. And then the last thing I have to do is look at the demographic. The highest risk is young, white, Caucasian males, right? Boom, I've done my risk assessment. I know if this is a higher risk person or a lower risk person to prescribe this to. And it's not that we want people to put everyone in a box and say they're high risk or low risk, but it really informs how I prescribe this drug and how I discuss it with that patient, okay, if they have those risk factors. How many of us consistently check PDMP? There we go. Okay, good number of hands. Yeah, I apologize. I know it's a pain in the ass, by the way. Right? I don't like the system either. They're actually making steps to improve it and to make it more accessible for physicians and easier to use. So hopefully those come down the pipeline and we have a PDMP that doesn't take 20 clicks and you get 20 names on it whenever you click on one person and have to click through all of them. But thank you very much for doing that important thing and checking your PDMPs. How many of us regularly counsel on the risk of opioids? Great. I see a good number of hands, and that's so important, especially with people who have comorbidities, any respiratory comorbidities, people who are already on benzos and other dangerous drugs. And then also just letting people know, hey, to some people, these are addictive as heck. So if you take them and you feel too good, this is probably not the drug that you should be using for pain. And how many of us are still prescribing opioids for back pain and headache? I see a lot of head shaking. I have a lot of people probably silently who say, sometimes, right? I mean, in my partner group, I see a lot of people who still prescribe for back pain and headaches, and I shake my head and go, oh, why are we still doing this? Because those are 2 indications where we know that there's harm with opioids, right? Back pain, people have much longer, prolonged pain and also have much higher rates of disability when we prescribe them opioids to try to control it. And headaches, too, they're not an effective medicine, and people get rebound headaches when they stop taking their opioids. So these are 2 things where there's a lot of guidelines, a lot of different literature that says this is bad to prescribe opioids to, but some of us still do it. And it's time that we kind of examine that practice and make that change to kind of go away from it. How many people saw this study? This made some waves, especially in the emergency medicine community. Huh? This was in the New England Medical Journal just last month. That kind of looked at the odds ratio of what happens if you're a high prescriber versus low prescriber. And I found this study really interesting because I think it really mirrors a lot of practice in different large groups like yours and like mine at Swedish. As we have some candy men and we have some people who aren't candy men, right? And in this study, it shows that in some low prescribers, they only got 7% of their patients got opioids. And the high prescribers, 25% got opioids, right? And I think that's something that's practice that people either think that, hey, these aren't as bad, or some people are really militant about not prescribing opioids. And I think with the data that's come out and with the scope of this epidemic, we really have to start moving more high prescribers toward low prescribers. Now, to go further into the study, the odds ratio, if you take a high prescriber versus a low prescriber, is 1 out of every 48 people who got an opioid for acute pain ended up a long-term user of opioids. Meaning that there was clinical inertia, your primary care doctor who saw you afterwards for the back saying, and you said, hey, doc, that Percocet really works. They said, well, crap, if the Percocet's working, let me write you another script. And here's a few refills, right? So a lot of those people, we turned 1 out of 48 for acute pain into long-term pain users. Now, if you think about it, you say, well, 1 out of 48 is not too bad. But how many patients do you guys see a year? Thousands, right? Especially across a group like yours. You see thousands of patients a year. And we create tens to hundreds of people in every emergency department who are either going to be long-term opioid users, prone to addiction, right? 1 out of every 4 long-term opioid users is addicted or becomes addicted to them, versus people who are not exposed to that risk and are not become addicted. And this is one of the big ways that we bend that addiction curve, is we become low utilizers. So that's kind of limiting opioids from the ED. Let's talk about alternatives to opioids, right? How many of you recognize this picture? New York Times created a big buzz too. This is an emergency department in Paterson, New Jersey. That got labeled an opioid-free ED. How many of you had heard this sexy term? Yeah? Okay. It's totally a farce, right? There's no such thing as an opioid-free ED. And this is kind of a news kind of labeling in it. At Swedish, we went to an ALTO protocol as well, and we got labeled opioid-free, much to the consternation of a lot of our people, and we got nasty letters from a lot of people saying, I can't believe you even mainly treat pain, blah, 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 blah. We're not opioid-free. We're just not opioid first, right? We think of all these alternatives. We bring all these alternatives to the bedside, and we have a lot of ways of treating pain besides just opioids. And that's really what we are in Swedish, and that's what we hope that all our pilot programs become places that have a big toolkit of medicines you can use to control pain that's not an opioid, and then have those discussions with those patients afterwards. Okay. So let's just run through this list. And you guys tell me if you guys are using these pretty consistently. The things at the top of the list are things that most departments are using. The things at the bottom are things that are rarely used, right? So how many of you are using ketamine, or does your ED have ketamine for pain? Awesome, right? How many of you are using Toradol? Great. And what's your dosage of Toradol? 15, great. So you've already made that kind of switch down to the lower pain dose Toradol, which is great. Good on you. How many of you are using Haldol? Right? Haldol, I see less hands, but Haldol is great for neuropathic pain, chronic abdominal pain, etc. It's my go-to drug for all my chronic cyclic vomiters, etc. So that's something that should definitely be in your toolkit. How many of you are using gabapentin, or at least starting to prescribe it? Again, good number of hands, around half, right? But that's another thing that you can start using, especially when there's a neuropathic component of pain. How many of you are doing trigger point injections? 2-ish? Okay, great. So this is something that can change. And this, to tell you the truth, this is the biggest change I've had in my pain practice, treating pain practice that I've had since my career. And of course, I've not got gray hair. I've not got anything else, right? But to tell you the truth, it's radically changed how I treat a lot of different pain. So today we're going to spend a good amount of time maybe doing some easy training on trigger points and kind of bringing you up to some of the evidence, ask questions. After this presentation, this is all going to be interactive on how to do these, okay? So trigger points. And the nice thing, too, if you're at any RVU based, you get to bill for these, right? This is a procedure just like any other procedure that can improve your RVU generation. And more importantly, help you control pain better. Lidocaine drips. So some pharmacies have adopted this, some pharmacies have not. Lidocaine drips we've started using very aggressively at Swedish for things like renal colic, and then also things like chronic abdominal pain and neuropathic pain. So this is something that, definitely when I have that chronic abdominal painer come in, they get Haldol and IV lidocaine from me. And it's amazing how many of those people who I get to turn around and can send them out. So this is something that comes from mostly the anesthesia literature, and there's one randomized control study from Iran about renal colic, but it's been widely applied in different EDs that really have kind of taken on this ALTO protocol approach to pain control. So this is
like the old cardiac stuff where you just bolus 100 in a drip, or
yeah. So the dosage of it is 2 mgs. So it's really this is mostly mixed by our nurses, and sometimes comes from our pharmacy. At the freestanding, we mix it ourselves, where you basically pull up. It's 2 mg per kg. We put in a 100 cc bag, right, and then we run it over 10 minutes. The max is 200 mg per kg, which is far below the toxic dose, right, which all of us remember from residency is 4 mg per kg. If it's 4 to 7, right? If it's not got epi, we never put epi in it unless you're also treating anaphylaxis and pain. But I wouldn't recommend that. Okay, but it's really easy to mix up at the bedside, and it's very easy for our pharmacist to compound. And now it's something that we use pretty frequently at Swedish for pain control. So definitely something that we can, again, it's about adding things to the toolbox so you've got something else to reach for instead of an opioid when it comes to pain control. DDAVP. Oh, okay. So renal colic, my thing right now is we basically get a shot of Toradol. They got 4 squirts of DDAVP in their nose, and they get an IV lidocaine drip. And for the great majority of my patients, that's adequate control, and I usually don't have to redose them, and I can figure out how big their stone is and send them out, right? So DDAVP has some pretty decent anti-ureteral spasm properties, right? It's used a lot in Australia, is really where a lot of that literature comes from. And it's an easy drug to give to patients, easy to administer, don't need an IV, and can start with some of the pain control that's from renal colic. Okay? Nitrous oxide. There we go. We got one who's using nitrous a lot, especially for procedures. Yep. So. Oh, did. Okay. I've been begging my ED staff to get me a nitrous machine because I used it in residency as well, mostly in pediatrics. Helped a lot with anxiety for pediatric patients. And some facilities they're using it a lot for fracture care management, reducing joints, etc. With this and other things. So that's something that's a little bit of a moonshot as well. But something where if your ED does have a few $100,000 that you're looking to spend, that's possibly a good utilization of that money.
Because we do have it up in OB now, they're using it for Yeah, but it was not a $200,000 machine. It was like. That's why we don't have it.
Yeah. You can. There's different ones, but yeah, the one I know that we were looking at, it was I think 100,000 or something else to use. But it's another thing. That's another tool that you could use for pain control and for procedural, for procedures, especially in kids. I find it the most helpful.
Is there anybody around that's using it?
We use it at one of our freestandings. So we have one freestanding ER that we can use nitrous in. We do have a lot of a big pediatric population there, but that's where I utilize it the most. It's not rocket science to use this stuff, Really, it's something that's easily titratable. You do it till the kid's a little goofy, and then you can oftentimes get away with doing procedures which otherwise would be pretty painful. So
we use it extensively in Australia.
Yeah,
and it's great.
We're using DDAVP too.
Not in my department. We weren't so much.
Okay, very cool.
It is advantage. It's quicker off.
Yeah, or knocking a kid out. Yeah, it's much quicker.
See, in the old days, they had to be able to self-administer. Is that still part of it, or not? With the new fancy machines, you can.
With the new fancy machines, we can. So I think there's ones that come just as like nasal prongs and other stuff, or masks. But yeah, we have both. So.
Well, that was the theory that we did.
Exactly.
Yeah, that was the old machine that we had because you couldn't. I mean, it was just like one volume, and so and then you're right. It'd fall off. Yeah,
exactly.
And then if you couldn't hold it, it would fall off. You didn't strap it on.
Yeah, but it's quick.
We heard that the places that have it, the staff sort of abuse it a little bit. I would say.
Definitely, nitrous can be abused. I think dentist's office, definitely they talk about that a lot. I'm not sure if any of our staff are abusing it. I hope not. Okay, and then finally nerve blocks. So great. There's a good number of us who do nerve blocks. I think, nerve blocks for femur fracture is by far the most common one. But people who are great at nerve blocks, I think you can tell that they work much better than any opioid for some of these really terrible fractures, So being more aggressive about utilizing nerve blocks in our practice is, again, another thing that we hope that people take on and become much more proficient in their practice. Trigger point injections, right? I'll be honest. When someone told me to do this, I thought it was snake oil. because, you know, there's this kind of band of muscle that's in tonic, you know, the thought is that there's this band of muscle that's kind of tonically contracting like a small Charlie horse. And then you go in and you either needle it or you inject some anesthetic in it. It releases that, and people get significant pain relief. I still don't understand the science behind it, but I'll tell you what, I cannot argue with a lot of the results that I get with patients. And there's a few indications that this is my go-to therapy or go-to second-line therapy when patients come in. That includes migraine headache. When my migraine cocktail doesn't work, they usually get an occipital nerve block or they get a trigger point injection. And it really helps you, one, control pain, get some amazing results with it. And two, people who don't want it, well, I guess that you're comfortable enough to go home. You know? Or that, you know, it kind of helps us frame that conversation as, oh, well, is the pain really bad or not? And it helps me get a lot of my chronic headaches out the door. And a lot of people now come in requesting these from our practice, you know. So it's something that does really have good efficacy, that's used in a lot of pain clinics, and that's really darn easy to do. The other thing I use it a lot for is lumbar back pain. You know, lumbar back pain's pretty damn common, right? We see it pretty every day, and it's something that I find is one of the most effective ways to control it. It's the quickest way, you know, besides just giving a shot of Toradol, the muscle relaxant, et cetera, to actually go to ask them where they hurt and then to inject that area with the local anesthetic. I've gotten some amazing results from people with acute back pain.
So is it immediate, and how long does it last?
Usually you inject it. You give it. I tell people 10, 15 minutes you should feel some relief, and that's usually when I go back and do my reassessment of them and see if we've had a positive result. Yeah. How long it lasts? You know, definitely I use Marcaine, so a longer lasting agent. It gets people out of that acute phase. If people believe in that kind of, you know, trigger point, you're going to end that spasm, that localized spasm, then you can think it lasts longer. But for migraines, helps break the migraine cycle. For lumbar back pain, I find it just gets people comfortable enough that I can get them home and get them home happy with other medications, non-narcotics to control their pain. Okay. And then also for musculoskeletal pains, you know, torticollis, use it a lot. Really, the evidence for it in the kind of first case that I ever had that made me believe that the snake oil was real was a gentleman who came in who was a police chief in my former practice in Oregon. And he had terrible post-herpetic neuralgia, was taking Percocets like crazy. He came in and he said, "Doc, I can't sleep. This stuff just is not working, and I feel like all I'm doing is trying to drug myself out." And I said, "Hey, I'll try this. I don't know if it's going to work at all." I gave him a trigger point injection. His pain went from 8 to a 1. I don't know if it's placebo. I don't know if there's actually some magic to it. But he got out of the ED and came back for one actually 2 days later, and we did it again. And it was something that he got pretty instant relief from it. And really trigger points, especially the cervical ones we think of, help modulate. They're a super optic nerve, pain modulator center, whatever. We try to medicalize all these things that we don't really understand. But I'll tell you what, they work. Yeah, and that at the end of the day is why I do them a lot, and why I think our patients appreciate them. But anyways, for the traditional trigger point, you're supposed to feel this tight band of muscle, kind of like if you've ever given a massage and you felt like one of those little tight bands. If it's painful and people have a positive jump test where you push on that area and they go, "Oh, that hurts," that's really the place that you inject, right? Again, this isn't rocket science. So I'm pretty liberal about where I inject, and I usually use lidocaine and Marcaine to do those. And after this presentation, if we can get a volunteer, I'll kind of walk you guys through kind of how to do these, because they're really safe, they're really damn easy, and again, it's something else that you can put in your back pocket to help treat pain, and pretty damn common pain. Headaches, back pain, I mean, those are 2 of the top 10 reasons why people come to the ED. So if you have something that's new in your tool belt to use for those indications, it helps you avoid using an opioid. That's great. Harm reduction. How many of you are familiar with harm reduction? You got 2, you got 3, some kind of half thing. Kind of, somewhat, you know. I know the principle. So a lot of you, I don't know if Boulder is the same as Denver. I'm sure you are. What has happened to your heroin population in the last 5 years? It's through the roof, right? A lot of times, you know, people get addicted and then their doctor says, "Hey, I think you have a problem." They cut them off. The easiest place to turn to is the street to get these drugs, right? It's cheaper. It's you don't have to go through a doc to it and kind of make up a story or do anything else, and it gives you a hell of a high. So there's a lot of reasons why people have stopped going through prescription drugs and started using heroin. And plus, now that we know that Americans love opioids, the heroin trade down south of our border in Mexico has just boomed. They're the second largest producer. Mexico is the second largest producer of heroin outside of Afghanistan because Americans love it, right? So it's kind of a sad thing, but it's a reality. And when you look at the numbers that just got released, and the top ones are preliminary, it is absolutely crazy how heroin and heroin overdoses have boomed in Colorado and across the country. 2001, we had 23 heroin overdoses, right? 2001. 2010, we had 46. This 2016, our last year, preliminary data, almost 200, right? And that's with Narcan in the streets. That's with reversing a lot of these overdoses. And you can see how big and how prevalent a problem this has become, both here and across the country. So harm reduction. Harm reduction, right, is a really different mentality for how we approach our people who are addicted to IV drug use. And I think it's the right mentality to have with people addicted to IV drugs. First, it kind of changes for how we view addiction, right? Which is not as a moral failing. It's not this addict, this person doesn't have the moral constitution to not use heroin. It's a medical problem, people. It's got a biophysiologic basis. Some people are more prone to it than others. There's true changes that happen at a physiologic level with addiction, and we've got to try to treat it like a medical disease instead of a moral failing. It also helps you talk with your patients and be more understanding of their plight. Okay? We have to treat addiction like a medical problem and not a moral failing if we're going to help to reach them. Now let me ask a question. This is one of my favorite questions from this presentation. Is how many of you know how to inject heroin? One.
No, not that I'm good at. When I've come across patients, and even when I was in Iraq and Afghanistan, some of my military buddies, I ask, it's like, I'm just curious, where do you find a vein? Where do you, and patients that I've seen come in with an infection, where's your choice where you shoot up and why? Yeah.
No, that is awesome. I've given this presentation around 5 times to different large ED groups. You're the first person to raise your hand and say, I have the first inkling of how it is to inject heroin and what the steps are, right? So let me ask a totally different thing. Person comes in and they have an STD. How many of you know how to counsel on safe sex? And do it regularly, right? All of us do it. In fact, you're not doing your job if someone comes in and they've got rip-roaring gonorrhea and you don't ask, hey, how did you get this? Like, how many partners do you have? What type of intercourse are you having? Are you using condoms, no condoms? Right? That's basic harm reduction. If someone's riding their bicycle, Boulder, right? You guys are the bicycle riding capital of the world, and they're not wearing a helmet, what do you tell them? Wear your friggin' helmet. It could save your life, right? But for some reason, when it comes to heroin and IV drug use, we kind of had a brain fart, and we decided that the best thing to tell people was, hey, stop using. This is going to kill you. You're going to get endocarditis. You're going to get blah, 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 blah. And then we actually don't dig in and figure out why people are coming in with abscesses. You don't know how they're injecting. You should know how to inject heroin. And when you're draining an abscess, you should say, tell me what your injection practice is. Right? So heroin comes in a little, usually, black tar heroin is the predominant type that we have here in Denver. It comes in this tarry substance that you put in a cooker, right? That you take some water, you put it in the cooker, hopefully sterile water. You cook your heroin to dissolve it. Sometimes if it's really tough, you add a little vitamin C or something acidic. Vitamin C would be great. Some people put orange juice or lime juice in it, right? After you dissolve it, you use a syringe, you use a cotton to kind of help dissolve some stuff out. You pull it up, you find a vein, hopefully clean your skin, and you inject. Any of those steps, if done improperly, can be how people get hepatitis C, which is the number one way that people get hepatitis C nowadays is bad injection, right? HIV, which is one of the major causes of HIV. If you think about that case in Indiana, one small town, 400 cases. 4,000 people a town, 400 cases of HIV. because no one took the time to tell them how to inject properly, right? This is really one of the biggest changes you have to make to your practice, is when you're sitting down and you're draining this abscess, ask what people are doing, and you'll be amazed. Oh, well, I didn't have enough, so I used some spit, or I just used any type of water source. A lot of people inject in the bathroom. Hey, toilet water, make sure you get it from the top, not the bottom. It's amazing when you actually talk with your people who are coming in with heroin and injection drug use problems, what they're doing. And they learn it from other people who have been injecting drugs. So this is your chance to say, you can do a few things really simple and never come in for me to drain an abscess again. One, you can use a sterile water source. Two, clean your skin. Get a pack of alcohol pads at the pharmacy. $5, you're going to be able to clean your skin. Have a sterile injection site. You're not going to get an abscess, or at least not going to introduce an abscess. 3, don't use spit. Spit is bad, right? You start actually talking with people about what they're doing instead of telling them, hey, just don't do it. You're going to be making a big difference in how that patient goes about their life.
Just to interject too, our health department actually has a no harm program that it's not just a needle exchange, but when they go in, they give them like the sterile little melting pots and little saline, I mean, all clean stuff to help. And if you're going to be addicted, at least do it right, like you said, so you can refer them there.
Yep, and let me ask, hepatitis C, because this is the biggest misunderstanding people have. 24% of our IV drug users in Denver have hepatitis C. 1% have HIV. And the reason why is because hepatitis C is a really hardy virus. It lives in things for up to 3 weeks' time. And if you help share your cottons with people, if you share your syringes with people, if you share your cooker with people, those can all be repositories for hepatitis C. So you should never share those. You should never basically, get those from your friends. And this is all counseling that I give to my heroin addicts while I'm draining their IND. I basically sit down, we have a conversation, ask them how they got hooked. And then we kind of go into, hey, how are you using? Because I want to make sure this never happens to you again. I usually don't say, quit, this is bad for you. No crap, Sherlock. Everyone knows that. You're not coming with any new information for that patient. They know it's bad. It doesn't take a friggin' rocket scientist. Most of these people would love to quit, right? But if you kind of arm them with that medical information that they need to know how to inject safely, that's really going to make a difference, and it's going to show that patient you actually give a shit, right? Because a lot of heroin addicts and IV drug users right now, their view of the ED is like despair. They hate being there. You know that because every time you reverse one with Narcan and you save their life, they go, when can I sign on to AMA, right? The ED is not a safe place for addicts, and we need to really start changing that and start changing that narrative because, to tell you the truth, they need to be there and we need to provide them more compassionate care. This is one of the ways where you go through how to inject and how to inject safely that people actually start listening to you. Okay? So something that we should all do is learn how to inject heroin, learn the steps, learn how to do it safely. It's going to change how you manage a very common problem. It's going to help you prevent hepatitis C and HIV. And by the way, who gets the most needle sticks, tough starts? You're going to protect your nurses and you're going to protect yourself, right? Because that IV drug using population has some of the worst veins. We all know this. And then they come to you or they go to a nurse or to someone else and say, hey, we can't get an IV on this person and they're sick. And that's when we get a lot of our needle sticks. So you're keeping not only that population safe, you're keeping your staff safe. You should do it. Syringe access programs. This is a new phrase for needle exchange, by the way, syringe access programs. How many of you commonly refer people to syringe access?
Health department for our locations. Maybe I'll find
You guys have great. You guys in Boulder have some of the best syringe access in Colorado by far. I'm somewhat amazed that you guys don't refer people to them. You got to.
Honestly, I think they do such a good job. I think that our hospital really is pretty different than a lot of different hospitals.
That's great.
I was looking at the data prior to our talk, and we saw in our ED of 40,000 patients last year, we saw 40 heroin overdoses.
Oh wow. Yeah. So it's pretty small, which is great.
They have a huge population that they serve. I think it's over 1,000. But even though we should be aware of it, and we should, are you using the program? And there's 4 locations. There's one in like Lafayette, Longmont, and then 2 here.
Well, they're plugged in with mental health partners.
Exactly.
A lot of the,
you guys have wonderful resources, and really it does. But I think that that thought is pretty true, though, that we should really be using these. These are some of our best partners for these patients. And it's been a change in my practice. Well, we went through a department that I asked people, do you know about Harm Reduction Action Center? None of my partners did. And now every time that people come in and they've overdosed, we all refer them to needle exchange. Because they're going to do a hell of a lot better job teaching them how to inject safely than my little talk. They're going to give them the supplies that they need, and then they're going to give them free HIV and hepatitis C testing. And your place up here in the works does the same. The works in the health department does the same thing. So when someone comes in, we should be referring these people to needle exchanges and syringe access centers in the same way that we'd refer, a fractured humerus to an orthopedist, because that's really where they need to go to start getting that help. So a big change that we can all make. How many of you prescribe naloxone? One. Okay, wonderful. This is something that, again, is a big change. I made a 180 on naloxone. I remember going to the ACEP council. Someone said, there was a resolution that we should be prescribing naloxone from the ED. It got voted down unanimously, right? Mostly because of the stigma of drug use and the fact that we're enabling users, to experiment with heroin and to do all these wonderful things, and we're giving them permission to use. That's a lot of backwards ass thinking. Let's be honest. You're doing one thing when you prescribe naloxone to someone. You're enabling them to save their life or to save their friend's life. That's really the one thing you're enabling, right? How many of your addicts like naloxone? None of them do. None of them take naloxone for shits and giggles, right? Because it puts them in immediate withdrawal. They feel horrible when they use it. It's not a drug of abuse. But what's the alternative, right? Someone overdoses right in front of someone. Maybe they don't want to call the cops because they're scared of legal risk, which, by the way, Colorado's done away with. But still, there's that stigma. There's those rumors. And that patient might just die. They might not get another chance at life if you don't prescribe it. So we should be prescribing this a lot. And if you don't want to prescribe it, I prescribe it. I read a thing for it and say, hey, you should fill this with both medical overdoses, where there's family who've seen it and who are on a high number of opioids, and for people who overdose on heroin. That's part of being a consistent message that's going to keep people safe until the day that they're ready to quit. Right? We have to keep people safe until the day that they're ready to quit.
How do you write it?
So there's three different ways. Invisio auto-injector, don't do that. It's like 2,000 bones, right? There's two. You can write just a syringe of naloxone and give them a MAD dispenser, and they can either intranasally do it, or a lot of our people who are IV drug users and in that IV drug using community prefer the injection. They're good with needles, and they all know how to kind of just access that. So those are the two ways to write it. We write intranasal and we write injection. Over the counter in most pharmacies in Colorado, right? The only thing my prescription does is legitimizes it and tell them it's a good idea. But really, they could walk in at any time. Any of us can walk in right now to most pharmacies and say, hey, I'd like some naloxone, and it's given to us. There's a standing physician order for naloxone. The problem is a lot of people, especially new users, don't know about it. And we, as the medical community, haven't done our role in reinforcing it as good practice. So we need to change that. We need to reinforce that harm reduction is an important thing. There's some places that are DCing people with naloxone. This is by far the best practice, right? To actually give someone a vial of naloxone and have them walk out the door. Denver Health is doing that. There's a few different funding opportunities that are coming up through Colorado Hospital Association to try to do this in other really high using areas, but that's by far the safest way to do it. Hopefully we can all move that direction, but in places that cannot, I think writing a prescription for people is a really important next step. I love the harm reduction section because people, it's kind of mind-blowing what we're not doing. At least it was for me, right? Kind of all this general common sense, smack myself in the middle of the head, kind of why am I not doing that for my patients who are addicted to these drugs or using IV drugs? It's one of the biggest changes you can add to your practice. This is one of the most aspirational, and maybe it's good to ask Tim. Tim, what are your guys' basic ability to refer to medically assisted treatment?
Well, we have there's a facility in town called the Addiction Recovery Center.
Awesome.
That, they do both narcotic and alcohol withdrawal as well as treatment.
Awesome. So you guys have a great resource that, I wish I had at Swedish, because a lot of these people we cannot get into an addiction treatment center, period. In a lot of places, and this is by far kind of the evidence that's coming out and where we should be moving, is we should actually be inducing people on buprenorphine when they come in, so basically withdrawing from opioids and wanting help. And after we do our induction of buprenorphine, we should be able to refer them within a few days to get to a medically assisted treatment program where they can get kind of that whole both pharmacological treatment and then the psychological treatment that they need to get through their addiction and hopefully enter into recovery. That's really where we need to go if we're going to turn around some of the people who are addicted in our community in this country and make the ED a place that's an easy referral point where we can get people to addiction. Again, that's an aspirational goal, but that's really what we're going to need to go toward in order to really help address this here in Colorado and across the country. And what's growing consensus is going to be the next best practice. How many have done a buprenorphine induction or a Suboxone? No, it's pretty damn easy, to tell you the truth, but definitely something that might be a new wave thing, but we have to have some place to send these people. And thankfully, a lot of the primary care doctors are starting to say, hey, you know what, we're going to add an addiction component, we're going to be prescribers. And if we can get that primary care community to kind of step up and say that they're willing to take on that, if we can open more MAT programs, then really the step is going to be us as emergency physicians saying, hey, we're willing to help, because no one sees addicts the way we do, right? No one in medicine does. They don't see that. They don't see the abscesses. They don't see the acute overdose. They don't see the people who are coming in with terrible withdrawal saying, I need help. We're a huge part in this wheel, and we're the cog of the wheel, basically, in getting these people into recovery. So.
Do you need a special license right now?
So, great question. So right now, to be a long-term prescriber of Suboxone, you need a special license. There's a 3-day exception that the ED can use, where we can basically do the induction, get someone on Suboxone, and they can return to the ED 3 days in a row in order to get a single dose, transitioning them to addiction clinic. And this is for people who come in on the weekends, on Friday or Saturday, and the office isn't open. So there's actually a whole carve-out in the law that says that ED physicians can prescribe this. Okay.
Meaning give them their dose, right?
Yep, you got it. Yep. Yep.
There's nowhere for them to go back.
Yeah, exactly. And I mean, you can't induce them if they've got, you're sending them out into oblivion. So that's why a lot of people, we're not doing this yet. But I think definitely when it comes to a time when we actually do have enough MATs, and this is a common referral, this is, I think, going to be another part of our practice, is making sure that we don't send people out in florid withdrawal, right? So, because what are they going to do if they're in florid withdrawal? They're going to use again, right? No crap. They feel like absolute dog garbage. They're going to use again. And when they're in withdrawal is one of the highest rates of overdose time, right? Because they feel like crap. They give themselves a big dose. Their overdose risk is some of the highest during times of really acute withdrawal. So this is something, again, we can be doing a heck of a lot more for these patients in the future, something that's just on everyone's radar to kind of start doing. So what can you do? Basically, my ask of you is going to be these guidelines that we've worked very hard on really do contain a lot of fresh ideas. They contain a lot of treatments. They're made by emergency physicians at Colorado ACEP for emergency physicians. This is not some outside entity telling you how to practice medicine. This is kind of us bringing to the table a lot of things that we think could benefit you and benefit your patients, right? Kind of our story at Swedish is we went opioid-free. We went to an Alto protocol. Basically, now it's been almost a year ago, and our opioid prescribing has decreased by 33%, both in the emergency department, giving Dilaudid, giving morphine, etc., and then scripts that we're writing afterwards. That's a heck of a change, right? And we're hoping to show that when we implement this, we can replicate this across Colorado. And if all the emergency departments, we all get on the same page and say, hey, this is how we're treating pain. This is what we will prescribe for. This is what we're going to be doing. That we're going to really be able to make a concrete difference in how these patients are treated. You know, not only here in Boulder, down in Denver are two kind of big metro areas, but also kind of out on the plains, et cetera, where the opioid crisis is some of its worst.